Yeah, I think it's always important to recognise the achievements. We are an organisation which has over 3,000 staff, and we are delivering frontline patient care services every day. And it is really important to recognise that we are providing good quality, safe care for the population of the island. So I think it's really important that we talk about the things that are going well, whilst also acknowledging the areas where we need to make improvements. And this particular report highlights some real improvements that we've been able to demonstrate across the year around our strategic priorities around high quality, safe care, the cultural improvements that we want to see to be able to support staff retention and a good working environment. Our financial responsibilities, we take those very seriously. And then our ambitions for moving care into our communities. So home first, looking at building capacity in our communities. So a few things that I'd like to just flag, which are that we successfully retained our accreditation for the Association of Perioperative Practice, which means our theatres here at Nobles Hospital are high quality and safe. It's an external accreditation of excellence. Our antimicrobial stewardship programme has gone particularly well this year, and we are one of a handful of organisations internationally that has received level 2 accreditation. Our fostering and adoption service has gone from strength to strength and again received an incredibly positive regulation and inspection report revealing high quality services with really good progress around our ambitions there. We obviously are an island, and we rely very heavily on our links to our major trauma and critical care networks across. And again, we're part of that broader network, and those have been peer reviewed during the course of this year, and we have some excellent results. Just moving on to, the experience and some of our waiting times. We have made inroads into improvements in access to mental health services, and we've spoken about the plans to develop our Thrive service, and we have seen reductions in the waiting times for both children and adolescent mental health services, but also our counselling and wellbeing services. We've created the Manx Integrated Sexual Health Service during the course of the year, that integrated one-stop service, which is having really good outcomes. Our ambulatory assessment and treatment unit has been open a year, which is really preventing people from having to be admitted to hospital. Our first contact practitioners in the community, both in terms of physiotherapy and mental health, are really supporting primary care and providing increased access. So there are a lot of positives that we really should talk about, and whilst also not being complacent about the improvements that we need to make.
Positives and achievements they may be, but of course we look at the stats within that report, and the number of patients waiting for a first consultant outpatient appointment rose to 17,829, and the waiting list for a day case procedure increased to 23%. The cancer diagnosis target fell short, with only 63% of patients receiving a diagnosis or the all clear within 28 days of an urgent referral. That should have been at 75%, and we look back over the last few years, that's consistently being missed. But we're talking in percentages and targets, but there are real people, of course, behind these figures, and those few days or however much time it is that they're waiting for longer than they should be can mean the world. So what went wrong? Why were those targets missed?
So there's a variety of reasons, and if I just take each target one by one and just explain why we've got the variance. So if we talk about diagnostics, yes, we would love to have no more than 1% of our patients waiting longer than 6 weeks for a diagnostic test, whether that be an imaging test, pathology test, or an endoscopy. That is, the 1% is identified in our mandate and in the operating plan because it is considered a best practice standard, and it is something we are aiming for. However, it isn't a target or a KPI which comes with additional funding to be able to achieve that. So it is important that we monitor against it. It is important that we strive to achieve improved access into diagnostics. But we haven't got the funding to invest to make the incremental change which would see us meeting that best practice. It remains a commitment, and it remains something that we would wish to see incremental improvements on. We are just about to have a brand new MRI scanner installed that potentially will have the opportunity to increase the number of patients. We are always looking at how we can use all of our diagnostic equipment most efficiently. We've just had brand new endoscopy equipment installed into the hospital at Nobles. So these equipment changes, the asset replacement, do bring about efficiency in order to put more patients through those facilities. But fundamentally, I think what we have to keep in mind is that particular target is a best practice standard, and it comes from England. England is also missing the target, but England has invested several billions in creating what's called community diagnostic centres. So there are 170 community diagnostic centres in England, supplementing what is already in place in hospital settings. And of course, we haven't been able to make that investment. The cancer target, the faster diagnostic standard, it is incredibly important we work to achieve that. It replaced a number of the cancer targets, meaning and placing increased importance on being able to have a diagnosis by day 28 in order to plan treatment appropriately. And we have not been able to achieve that target consistently, primarily because of our inability to be able to recruit to a breast radiologist. So it is the issues that we've had, the challenges on the breast cancer pathway particularly, which has resulted in that performance falling below 75%. The good news is we have now recruited to a breast radiologist. They started in September. That's a substantive full-time appointment for Manx Care and supplements the other breast radiologists that we have. So we now have a sustainable service in addition to having a full-time breast surgeon. So we can see that again from this September that target is going to be achieved, and we should be able to achieve sustainable performance. That's
75%. You're hopeful this time, next annual report, you will have hit that 75% target?
Yes, we're on trajectory to achieve that in this year. It is always difficult because you can never anticipate what workforce changes you have or what increased demand that you have within these pathways. But what we do know is that the target has been particularly linked to our issues within the breast cancer pathway.
You mentioned there about the investment that's being put in across. You said Manx Care just doesn't have the funding to hit those diagnostics targets. How many more millions will it take for Manx Care to be able to have what you see as the required funding to hit these targets?
Gosh, I think that's a really difficult question to answer. We are committed to delivering our services as cost effectively as we can and in the best place, so in the right place at the right time with the right people. And for Manx Care and the Department of Health and Social Care, that means trying to move many of our services out into the community where it's much more cost effective to do those. And if you just make a direct comparison, a GP appointment costs around £50. An ED appointment is around £200. An ambulance journey into hospital is around £500. So it absolutely makes financial sense and improves outcomes and access for patients to be able to move our care into the community. We need to be able to respond to increases in demand and growth, but And that's why we do extensive financial planning. So it will depend broadly on what our mandate says, on what services are the most important for the island to deliver. So there is no sort of quick and easy amount of money that can be identified that we could say, actually, if health and care had this amount of funding, we could do everything and meet all of our targets.
But what's clear seems to be that it's not within the current budget.
I think our current budget allows us to meet a modest amount of year-on-year growth, and we have to then go through a process whereby we prioritise what is most important through a business case process.
Looking again then at the key performance indicators, and the ambulance response time was a couple of minutes late. The mean time was a couple of minutes late than targeted. So what's happening there? Why is that target being missed?
Yeah, I think that comes down to we're still operating on a model of delivery which we had in place about 30 years ago when the ambulance service was created. So we have 4 ambulances on duty during the day and 3 at night. And I think the ambulance service, I know they work incredibly hard to position themselves strategically across the course of the island in order to make sure that when those priority calls come in, they are in the best position possible to try and respond as quickly as possible and get where they need to be and get to that patient within those 7 minutes. And of course, we just slightly missed that target by 2 minutes. Again, really important we look at how we can do things differently. And over the last couple of years, we've put increased clinical support, what's called clinical navigators, into the emergency joint control room in order to be able to make sure we are upgrading calls when necessary and there is clinical oversight of those calls coming in so that the right judgment can be made. And also, downgrade calls when that's appropriate also. And then we have done a large piece of work in the last few months to be able to plan the future for the ambulance service. What does the level of demand on that service now look like? We've seen significant increases in demand for the ambulance service. There are new diversionary pathways. There is see and treat. See, treat and leave will be starting soon, whereby we have different opportunities to clinically assess patients and potentially not always bring them to hospital. And I think that's about the transformation of those services and also planning on what that service needs to look like in 5-10 years. So we can develop the business cases and we can articulate how that service needs to change in order to meet what we anticipate the demands of that service to look like. And a lot of healthcare is staying ahead of the curve around what we anticipate demand will look like and what are the contemporary models of practice that we need to move to. And so yes, it's something that we monitor really closely. There is clinical assessment of all of those calls coming in, and the service remains committed to making sure that we respond in a timely way to all of those calls.
And one area which I think consistently we've talked about through the years is A&E, the emergency department here at Nobles. We saw that target of getting patients in and out within 4 hours was missed as well. What could help there? What possibly would help that turnaround get quicker?
Yeah, so it is about looking at those alternative pathways outside of the hospital. So making sure that those using accident and emergency are genuinely need to come to the hospital. We know the ED department is quite small, and the number of patients being seen through the department has increased significantly over the years. There is a saying, if it can't be done in 4 hours, it can't be done in ED. And therefore, as part of our ward reconfiguration, we are developing a clinical decisions unit, which will be open in the next couple of months. And this allows patients who potentially need a longer amount of assessment, perhaps more diagnostics, to be assessed in this clinical decision unit without having to be fully admitted into a hospital bed. So it's a very important part of the pathway which is missing for us, and it's really important we put that in place. We should not be admitting people to hospital who don't need to be. But equally, our emergency department is neither the appropriate place nor big enough to respond to a patient who perhaps needs a suite of diagnostic tests in order for a decision about whether they need to come into hospital or not. So that clinical decision unit is a really important addition to our services here at Nobles alongside the ambulatory assessment and treatment unit. But it's really important we start the planning, the capital planning for having a new emergency department, because when we think about the demand, ED demand is unlikely to ever either stabilise or go down. We don't expect to see that, and no other health system expects to see that too. Whatever you put out into the community, we will always anticipate increased demand through the emergency department of at least 4%. So important we start to think about the capital development and having a new emergency department at some point in the future.
And finally, if I can just ask, you've already committed to hitting that 75% cancer target in terms of referrals. This time next year, are we going to see any of those KPIs in the red?
I would always hope not. All the actions we're taking around the emergency department, the cancer pathways, are all actions which are intended to ensure we consistently achieve those KPIs. It's always predicated on increases in demand and the ability to recruit to the right workforce with the right skills in order to sustain those pathways and to be able to give that consistent access standard and quality of care. But no, our focus is to ensure we are providing all of the right care and achieving those KPIs, and have plans in place to consistently achieve that.
We have to acknowledge the reaction to the annual report this week. And now Russian MHK Jill Watterson says, talking about that £15.6 million overspend last year, he says, in the last few weeks, we've discovered DHSC has put aside £4 million and Treasury has earmarked £10 million of its contingency fund in anticipation of another big overspend this year. Is that correct? Are we set for another big overspend at the end of the year?
So our month 4 position, which has been published, is showing an overspend, and we are forecasting to overspend in this financial year. The £10 million contingency fund was set aside, and that is being allocated. And these are cost pressures that are unavoidable and that have to be funded year on year. These are high-cost individual placements and various other programmes of work which we are committed to deliver as part of the mandate, which need a separate funding stream. So there has been complete agreement between Manx Care, the Department of Health and Social Care and Treasury as to the appropriate use of that contingency funding. And we remain committed to deliver on the cost improvement programme that we have signed up to, which is currently running at just under £11 million worth of savings in this financial year, and we're on trajectory to achieve that. And we are taking all appropriate actions internally to control the level of expenditure that is within our gift to control. So this is about really scrutinising all of our internal expenditure and looking at ways where we can reduce costs across a broad spectrum of programmes.
Do you think that's going to be enough? We're looking again at Mr. Watson's comment. He says he can't see a supplementary vote getting through next year, nor will Tynwald nor I hope the DHSC accept last-minute care cuts to slow spending before the year end. Just over halfway through the financial year, he says time's running out for Manx Care. What do you make of that comment there? Is time running out?
I think we are really transparent about what is the true costs of health and care. You know, what the island is experiencing is no different from any other country, any other jurisdiction. You know, and what we've had over the last year is a real commitment to develop a mandate and an operating plan for Manx Care, which recognises the financial responsibility and the constraints in which we're having to work. It means we potentially have some difficult choices to make, and there might be things which cannot continue to be funded. It's very difficult. It's not just within Manx Care's control. And that's why there's those very active conversations taking place with the department and Treasury about how we get onto a sustainable footing. What does financial recovery look like over a longer period of time? And what choices do we collectively want to make about what are the most important elements of health and care that we absolutely want to deliver, and perhaps what are less important. You know, added to this, transforming the way we do things is also really important. We have to continue to challenge ourselves to find innovative and different ways which are safe and effective of delivering healthcare, because sometimes our models of care, particularly in an island setting, mean that they're not always as efficient as they could be. And we have to think differently, and we are doing, but some of that, you know, does not happen overnight in health and care. Sometimes those changes require some double running. So you can't just switch off one way of doing something and start a very different way. There has to be a period of double running. You have to implement those safely, carefully, fully, in full consultation. And we cannot and should not underestimate the importance of getting that right for our clinicians, our practitioners, and most importantly, the public we serve. So change is necessary. Change is absolutely necessary and vital if we're going to provide safe, effective, sustainable healthcare. But we must do it carefully, and we must do it in consultation with all of our stakeholders.
So we're talking about potential cuts to services over the next 6 months. What would be the first to go? No,
I don't think we are. You know, I genuinely do not think we are looking at cuts to any of our services. That is not in our plans. Our plans do include doing things differently, but our plans do not include cutting any services. And that is the openness of the conversation we're having, which is about, you know, these are the areas that we can constrain expenditure, which is within our control as Manx Care, so being efficient and productive with the resourcing we have and making best use of it. But there's also broader conversations about other aspects of funding and choices which we must make collectively.
Is it a matter of survival over the next 6 months? Is the pressure now on Manx Care greater than it's ever been before?
No, I don't think so. I think as an organisation, we continue to make improvements year on year. And from our perspective, our focus is on delivering the best quality care for the population we serve. So whilst there are very important discussions day to day, externally, and that's part of my job as chief exec, you know, what is really, really important is that our day job and the day job for all of our staff absolutely continues, whatever that external environment is looking like. We are absolutely focused on what we need to do, and that is delivering against the mandate we have been given. And I think we can talk about the things we talked about at the government conference as evidence of that. We have put new contracts in place for our opticians, which will see increased activity in our communities. We have addressed the dental waiting list, and we should see that reduce. We are improving GP access. We have implemented intermediate care in our communities. We are developing our wellbeing hubs and moving care closer to home. And we have the evidence behind much of that achievement. And we are absolutely still focused on delivering everything that we need to within our mandate and absolutely not cutting any services.
So calls from certain MHKs for the Manx Care Board to resign and to consider your position, do they hold any weight? Do you see yourself thinking about that right now?
No, I'm committed to delivering the job I do to the best of my ability, and working constructively with the rest of the Manx Care Board to focus on our delivery. We all take our roles incredibly seriously. We care deeply about what we do, how we do it, and are committed to the island and its healthcare system. So, no, my job continues.
Perfect. I think that wraps my line of questions for you, really. Is there anything else you think we need to highlight or anything you'd like to address in terms of some of the comments out there?
Thank you for making it to the end of the Manx Radio Newscast. You are obviously someone with exquisite taste. May I politely suggest you might want to subscribe to this and a wide range of Manx Radio podcasts at your favourite podcast provider, so our best bits will magically appear on your smartphone. Thank you.